Okay, sorry about that. Okay, so everyone can see my screen, everyone can hear me. And a little bit public service announcement in the way for those of you who work in healthcare, ouch, or are not yet introduced to healthcare. If you look at the announcements, there is a lovely, oh, it's not here. I'll put it in there today. In a couple of days, there's a let's put it in here. What is it called? It is a employer spotlight, and I'm going to put it in here. Let me get a fake message. So we want to start the class. Okay. I'm going to put there an employer spotlight. It's going to be on June 30th. It's going to be online, and it's with Inova Healthcare Services. So they're always hiring. They're always looking for some people. So those of you who are looking for healthcare or want to break out in your, you've been doing the same healthcare thing for a while, and you want to break out to something maybe more administrative or maybe more clinical, it's the way to be. And I've shared this story with you guys a million times. Both my mother, not my mother, my wife, she acts like my mother, my wife and my daughter, that's how they got their jobs, and they got their jobs very, very quickly because they go to employer spotlights, they go to these hiring meetings and things of that matter. So go to as many of these things as you can and get networking so that get yourself a nice job and check it out. My wife transitioned from nursing to healthcare admin very easily, well, relatively easily, and now she's got a nice cushy stay-at-home job with Inova, full benefits, full everything, and doesn't have to work in the hospital anymore and can stay at home. But those opportunities are rare if you don't make yourself available for it. So weeks 1, 2, 3, 4, 5, and if you'll notice, I also put out on week 5, we're not going to do discussions anymore for the next 4 weeks. We're going to do, you're going to create a quiz. And you create a quiz based on case studies. And I put an example of a case study here. So if we go to, let's see, let's go through what we went through last week. Something that we went through last week. What was last week? Nervous system, right? Let me go to our textbook. And of course, this week we're doing urinary, but we go to our textbook, medical language lab, go to the ebook. And table of contents. And let's go to urinary since we're going to do that today. So when you go through urinary, like let's say we went through all the chapter. If you look at the end of the chapter, there's these case studies like this, that looks like kind of like a little bit of a patient's chart. And you can see the HPI, history of present illness, PMH, past medical history, PE, physical examination, your assessment, which is your diagnosis, plan, of course, is your management. You can see what doctor wrote it, right? And there's a whole bunch of medical terms you could see that follow that you can write a question on. And here's some examples of questions that you can turn into multiple choice items. And that's actually the secret to test taking. If you know how a test is designed, right? And for all of you future nurses, future NCLEX, this is exactly how not only your final for medical terminology is going to go down, this is actually how your NCLEX works. NCLEX works this way. They have a clinical vignette or some sort of clinical story, and then they have like questions regarding the clinical story. Can't see the screen. Let me see if I can reshare it. How's that now? Everyone can see the screen?
I can see it.
Okay, cool. So you look at this, at the cases, and you can ask questions about it, because we already went through the more, very basic way of looking at medical terminology. Like, what does rectal mean? What does abdomen mean? What are the parts? That's gone. Now we're going to talk what we do in real life. For example, I could ask you, you have a patient, James Jenkins. What is his HPI? It goes, what is his chief complaint? And right here, dysuria and urinary frequency. So you see dysuria, we already know that, well, we know dys is the prefix that means abnormal. Uria is state or condition of urination. So he has abnormal or painful urination. So I could ask, in James Jenkins' HPI, what is his chief complaint? Is it A, does he have a headache? B, does he urinate very little? C, is his urination painful? Or D, does he have diabetes? Right? That's a real question in real life, right? That everyone asks. What's the HPI of my patient? Why is he here? What's his chief complaint or his CC, right? I could ask about past mega history. He goes, did he ever have a TURP? Transurethral reception of the prostate, right? You'd have to know what TURP is, and then you'd have to know what this is, okay? And you go, so if he had a prostate problem, did he have a prostate diagnosis? Yes, no, maybe. Was it cancer? Yes, no, maybe. He had cancer, but it was what for the colon, and he had BPH, which is benign prostatic hypertrophy. Benign meaning what? It's not cancer. Hypertrophy. It was abnormal growth or excessive growth of his prostate. So this is the kind of thing that we'll be going forward. Of course, we'll be going over the lectures just as usual. The quizzes will maintain usual, but the discussions will now be, your job will be to design a quiz based on what you read here. And you could use these words here. And it's lovely how the textbook tells you what are the key words out of that case. And then it can give you sample questions that you could create into A, B, C, D, multiple choice. And if you know and understand multiple choice, it's then you'll know and understand your NCLEX, MCAT, GMAT, SATs, so on and so forth. Okay. And just as a little public service announcement, if you're preparing for your T's, please prepare for it. A lot of failures. Oh, it's so sad that so many people, they got their grades up, they got everything they need, and they can't pass their T's. I now have half a dozen students who are already on. You only can take the T's, I think twice or 3 times in a year. I forgot the number, but don't be that person banking on one more shot, because that's a horrible place to be in. Okay, so make sure to prepare for it. And one way to prepare is to actually create a quiz that you know is going to be in the format of your test-taking environment. So who's urology? Who's nephrology? Now, urology, they deal with anything that deals with the urinary tract. So here's your urinary tract. So your kidneys, that's nephrology. Okay, they're the stars of this urine making machine. But your ureters here, you got 2 of them. Your urinary bladder, which is right here, and your urethra, in this is a male. So the urologist deals with these 2 things, this thing, and this thing. Okay, your 2 ureters, your urinary bladder, and your urethra. Now, the urologist also deals with any sexual dysfunction for our male patient only. Now, who deals with sexual dysfunction for your female patient? That will be the gynecologist. But there's many now subspecialties of urogynecology who are fertility specialists for both male and female. Now, nephrology, they deal with the star right here, which is your kidney. Okay, it filters out blood and it makes urine. That's the main thing it does. But it does 5 or 6 other things that are really important. So when you have like a UTI, a urinary tract infection, you got something going on down here, it's of concern. But if it moves all the way up here to your kidneys, then we got to call another specialist, and that's your urologist. Okay. What's the bladder? The urinary bladder is cyst. And I know that cyst also means pus, but in this context, it means urinary bladder. Vesico is another term for urinary bladder. So we could perform a cystoscopy, which is the process of, right, of sticking in a tube. I stick a fiber optic tube here in your urinary meatus, down your urethra, and then I could look in there with a light and a camera and all that jazz. Vesicocele, hernial protrusion of the urinary bladder, also known as a cystocele. So vesicocystocele, everything has its own covering. If the urinary bladder starts poking out into spaces that it shouldn't be, it should be right here. And that's called a cystocele, also known as a vesicocele. Glomerulus, that is the main part. There's microscopic things going on in here in your kidney, here in the cortex part of your kidney. And there's these things called nephrons, which are these microscopic like filtering things, and you're going to learn that in anatomy and physiology. And within the nephron, you have this tuft of capillaries called your glomerulus, and it's synonymous with kidney dysfunction. So glomerulitis or nephroglomerulitis, that means inflammation or infection of a specific part of my kidney. Meatus, that just means opening, right? Because it's Latin, we don't pronounce it meatus, it's meatus or meatus or meatus. Nephroma, that's a tumor of your kidney. And remember, tumor just means lump or bump. And we don't know if it's cancer until it's a carcinonephroma or nephrocarcinoma. Renal, pertaining to the kidney. And remember, the Department of Nephrology, they're the ones who deal with the kidney. So let's say I'm a urologist and then things get out of hand. It goes all the way up to the kidney, and that's a problem. So then I will now refer my patient from urology to nephrology. Renal pelvis. Now, the renal pelvis is this part of your, right here, of your kidney. Now, your kidney filters out, filters the blood and makes urine through these set of funnels. And the main funnel that goes right before it goes to the ureter is your renal pelvis. And that's area right here. And that renal pelvis is called pyelo. So if that gets damaged, I have to do a surgical repair called pyeloplasty. Uremia, emia, we know is state of condition. Em means blood. So the function of your kidneys is to filter out nitrogenous waste. Urine, that's what urine has in it. It has nitrogenous waste, things that should be in the toilet. Now, if your kidneys aren't doing your job, that nitrogenous waste starts backing up into your blood, and that's called uremia. Urinary, of course, pertaining to urine. Another way to called urination is voiding or passing. They use all these terms. Uretostenosis. Your ureters or any of the tubing could be stenosed or narrowed, starts having stricture. So let's say, for example, you got a bad UTI and it's called ureteritis. What's going to happen over time? And this is an exaggerated tube. In real life, this tube is about as thin as this black line right here. It's very thin, less than a millimeter wide. That's why if you have a stone in there, and it's very easy to get stenosis, ureterostenosis. And you could also get a urethrocoele, a hernial protrusion of your urethra. And you can see here, your urethra is here, but if it starts to out pocket or bulge out in the wrong place, and that's called a urethrocoele, okay? Emia, blood condition. Now let's look at some other blood conditions. So remember we had uremia, right? So that's when the blood, when the unfiltered blood gets backed up, and then we have a state of condition of a blood condition of urine or nitrogen. Nitrogen waste. That's the best way to put it. Now, azotemia is the same thing. It's the same exact thing as this. They're both the same thing. How's this? I'll do this. Make an equal sign. So doesn't that look like a beautiful? Now, how about if I have hyperemia? Don't I have a blood condition of too much blood? Yep. How about if I have anemia? State of condition of no or little blood? Yeah. How about if I have no, that's not going for me. You guys get the picture, right? Beating a dead horse and you do that. Lysis, iasis, is just like osis, abnormal condition. So lithiasis is lith means stone, and wherever you have salt, sugar, and fat, you can make a stone, and you can make a kidney stone. And kidney stones are mean because remember I told you this ureter is very, very thin? Well, that stone is going to go there and it's a scrape here. It could scrape here, and it's very, very painful. A kidney stone or lithiasis or nephrolithiasis is probably the only time a male patient ever knows what childbirth feels like. And I've told you guys the story of my wife. I asked her if the level of pain was 1 to 10, 10 being the worst. She said 9 and 8. And I said, well, you lived through how many childbirths? She goes, yeah, it's that bad. It's just as bad as childbirth. And
kidney stones are worse than childbirth. I've had them.
Yeah, my wife said I think she was being polite when she said just as bad. And my wife had 5 kids. So,
oh God.
So she was like, and I go, you sure? And I go,
I've had 2, and I promise
you lived through a lot of stuff, lady. And
yeah, if you hear a guy complain,
like, no,
you don't feel bad.
This was like 2 months ago. She was like, no, it's bad. And I go, nah, it's just that you're old. Maybe you can't handle it. And she was like, no, she goes, I can't wait until you get them. And I'm like, oh no,
God, dude, you don't want them. Oh,
no,
God.
I don't. My last patient was 59 years old, and he was a pretty tough guy. He was on the ground, screaming.
Yeah,
I had to sedate him, and he was on the ground screaming.
The pain is so bad, you can't breathe. You can't.
Yeah,
like standing, sitting does nothing for it.
She couldn't cry. She couldn't do anything. And then
yeah,
and even where we were giving her some hardcore meds, she even said a scale of 1 to 10, it's still 5. It's around a 5, but I can breathe now. And I'm like, I put you on a morphine drip. And she was like, yeah, I'm still feeling it. And then she was kind of getting angry because I wasn't. She was like, you're being a doctor right now. I hate when she says that. Another way of saying you're being an a-hole. Right?
Yeah.
The nurse was looking at me like, I think you should shut up now. And I'm like, yeah, I think that's a good idea. But yes, if you guys have any lithiasis or nephrolithiasis or any stone, listen to your patient, especially if your patient is female and had children, right? They know what pain is. Now, I'm a dude. So when I feel pain, I'm a big baby about it. So you listen to me with like a grain of salt. You're like, yeah, but any mommies out there, yeah. As a man, I wouldn't trade places regarding pain. And as a medical professional that's seen thousands of patients in pain, there's a reason why whoever made us made women have a much, much higher tolerance for pain. And it is a medical fact that's proven that women have a much higher tolerance, almost tenfold than men. That's why any of you who do phlebotomy or do any clinical procedures, be careful for the biggest guy in the room. And especially if they're a cop or a fireman, something in like a macho position, they're the first ones to faint. They're the first ones to break. So be careful of them. Dialysis. Dia means complete or thorough. Lysis is breakdown. And that's what we're doing with that big, big machine. Your kidney is such a small thing, and that big machine, the size of like a small refrigerator, it's called a Fresenius machine. And that's what it does. It removes, and it only does 1 out of the 5 things that your kidney does. So you have to be amazed at what the human body can do for you. And that's why we all, myself included, we got to really take care of this body, because it's the most advanced machine ever, and you're in charge of it. Nephropathy, of course, we go to nephrology, any kidney disease. Nephropexy, when we take out the kidney and repair it and do our nephroplasty, I have to put it back in the right place in your back so it doesn't droop down, because if it droops down, I get nephrotosis, and that's a bad thing because sometimes the ureter kinks up and then there's a problem. The way we take care of the stones, we do something called lithotripsy, and there's several ways to do it. There's surgical, there's laparoscopic, there's also there's this other thing we're going to show you a little bit further that's called ESWL, extracorporeal shockwave lithotripsy. Say that 25 times fast, but ESWL, and we're going to show you a picture of it. But all intents and purposes, tripsy, the process of breaking down or crushing lith stones. Now let's look at urea, because that's a suffix that's going to talk about a lot of things. So polyuria, of course, is the state or condition of excess urination or too much urination. Can I have oliguria, which is a state or condition of decreasing or declining urination? That's not a good thing. Typically, in a day, your patient should have like around 1,800 cc's or 1.8 liters of urine. You'll see something like this. It's going down. It's going from 1,000 to 800 to 500 to 200 a day, and that's oliguria. That is scary because it's going to lead to anuria, which is a state or condition of no urination. Anuria, we don't want to get to this level because this is already kidney failure. If your kidneys aren't working, it won't make urine. As long as the blood is pumping, as long as you're alive, as long as your heart is pumping and you have blood pressure, you should have always urine production. I always tell this odd story of when I was a kid. Didn't any of you guys ever notice when you were a kid, like you can always pee? Like, I thought it was very interesting. I think I was like 4 years old or 5 years old. I'd pee and then I'd walk, take a couple of steps, and then I'd go back and pee just a little more, just a drop. And then I'd walk like 6 or 7 steps and I'd pee just another drop. And I just remember my cousin, and now, ironically, she's a nurse now. She's much older than me, but she used to think I was crazy. Like, and she's like, "You got to hold it a little bit." But in reality, is when you need to pee, you should pee. But you'll constantly make urine, and too much is not a good thing. Too little is not a good thing. Nothing is not a good thing regarding nephrology. And these are your classic terms for the different types of urination. I could also have hematuria, which is not a good thing. That's a state of condition of blood in my urine. I could have lipiduria. That's not good either. That's when your urine gets really cloudy. That's fat in my urine. Why say my urine? It's not my urine. Jeez. Urine, generally, it's not mine. Hematuria, lipiduria, proteinuria. How's that one? See, the list can go on, right? I don't need proteins in my urine. That's not a good thing. So, and you'll learn that in your med surg and anatomy and physiology stuff. And these are the different kinds of things that can go on with urination. Okay. Oh, this is the nephron. This is microscopic. And this is called the glomerulus, or the tuft of capillaries that's going to filter out your blood. So your dirty blood comes here in your renal artery and it goes up here in your cortex. It filters all out in about 500,000 of these microscopic things. And these things are called nephrons. And then it empties out into all of these funnels and it gets into the renal pelvis here, renal pelvis into your ureter. Of course, here your adrenal glands, adrenal, ad means on top of, renal means pertaining to your kidney. So your adrenal glands is right on top of your kidney. Nephro, renal, kidney. Ooh, stones. Ooh, no bueno, right? And the bad part is, see this, when they break off, they'll go and they'll scrape, they'll scratch, and then you'll have hematuria. We could do ESWL, extracorporeal shockwave lithotripsy, to break up some of the things, or sometimes we'll do what we'll call a percutaneous tap. I can do I could scope you by drilling a hole in your back and then poking your kidney that way, and it's ultrasound guided. Where's the ESWL? Oh, here it is. ESWL is you sit on this table and there's a shockwave generator, extracorporeal. Corpo means your body. So pertaining to out of your body, there's shock waves that go in here and break up stones. And hopefully then you try to, we try to give you a medication to make you pass the stones. And then we give you a whole bunch of pain meds. And we give some serious pain meds. You know, the happy stuff. But man, it's really, really rough. That stuff, not good. Let's see. Here's the thing that I was talking about, percutaneous nephrostomy. I could stick a tube in here, right? And then we could scope it, see things, and we could either rotor-rooter it out. We even, because there's even some institutions here in the United States that on the tip of the scope has a small explosive, and it blows up. It breaks the kidney stone into smaller pieces. The cutoff is usually around 3 to 5 millimeters, which is really huge because remember I told you this was exaggerated? This thing is barely a millimeter. In real life, your ureter is like as thin as this thing, but they draw it this way so it's exaggerated so you can see it. So you could see here percutaneous nephrostopy. So I take a nephrostomy stoma. I'm creating a hole in my kidney. And why am I doing that? Let's say, for example, I did some surgery here or I did some stuff here and I want this to heal. I don't want urine to come down here. So I put a nephrostomy tube so the urine can go in the catheter bag. And then, of course, we monitor it and make sure, you know, how much urine you got going in and out. And for you future nurses, that's a very important thing. Intake and outtake of fluids, very, very important. It is one of the main things you do all day, every day. Vesico, cysto, Raffi, suturing, repair. You already know that. Okay, let's talk about herniations or seal. Now, female patient, right? Now, what happens when you have like 1 million babies like my wife? No, actually, you have to have more than that. Like 8, 9 children. You know, the most I had was mommy who had her 11th pregnancy and she had 8 kids. Now, what happened post-op? When you have that many children, you see all the muscles here. Let's make it a little bigger so maybe we can see. These are the muscles here you see here of the pelvic floor. Part of the muscles here of the pelvic floor hold certain tubes together. And here's your anus, your sphincter here, but there's also muscles here too. So what are the main tubes? This is one main tube, the rectum. Here's another main tube, which is the vagina. And here's another tube, of course, is your urethra. Now you add seal to it, the suffix CELE, that means it's a what? it's a protrusion or an herniation. And herniation just simply means an outpocketing or sticking, an organ system sticking out where it doesn't belong. So let's say if this whole pelvic floor got loosened because mommy here had a lot of babies. So this would come out, and that would be called a urethrocoel. This could come out, that's called a vaginocele, also known as a colpocele. And this could come out, that is called a rectocele. Or when that tube comes out, it's called rectal prolapse or vaginal prolapse or urethral prolapse. And it happens when there's a weakness of the pelvic floor for whatever reason, but the most common reason is multigravid mommy. And it's got to be multigravid like 8, 9, 10. And the last time I saw a serious case of all 3 tubes sticking out was, like I said, I had mommy, she had, I forgot, it was 8 or 9 children, and it was her 11th pregnancy, something like that. And I was dealing with her post-op, and all of this came out. Every time she sneezed, a little urine would come out, this would pop out, this would pop out, and that's called either rectocele or a cystoscele, which is this right here, this tube right here, and a vaginocele, which is this tube right here. Here's another way that I could look into a male bladder or even a female bladder. I put a scope. Of course, we sedate the patient, and I put it down the urethra, and we look at it, and we also can record it. And the neat thing about any scope or scopy is that I can record it and I could give it to another doctor, and we can have an instant second opinion. So the instrument is called a cystoscope. The process is called cystoscopy. And the recording is called the cystogram. Algia, dynia, that's pain, usually comes in the form of some severe cramping. UTI, urinary tract infection. Now, UTI is not synonymous with STD. Like an STD can be a UTI, but not all UTIs are STDs or sexually transmitted diseases, especially with children. Because, kids are dirty, dirty creatures. So they're touching themselves down there all the time. Female patients are more prone to UTIs because the urethral passageway is very close to the anus, and also it's very, very short. So you could be super, super clean hygienically, and you'll still have a greater predisposition. But with the male patient, the problem with them is they're almost 90% asymptomatic on their UTIs. That's why their UTIs progress to chronic, progress to kidney problems. Doesn't happen that way with female. And with female patients, they tend to go to the doctor more often for even the most a minor thing. Okay, someone got disconnected. Okay. Oh, good. I'm still recording. And remember, tumors, right, could either be malignant or benign. I mean, cancers could be either malignant or benign, right? And remember, malignant, they grow quicker, faster, spread faster, and have a greater disposition for metastasis. But non-cancerous things and benign things like to stay in one place. They like to hang out, which is a good thing. Let's move on. Again, another picture of your nephron. Going to pyelo. Oh, watch out for this. Pyelo versus pyo. Pyo, think pus, which is dead white blood cells plus dead bacteria, right? But pyelo is your renal pelvis. So pyelopathy, right, is a disease state of that one junction We already showed it right before it goes into the ureter, and that's called the renal pelvis. It's pyelopathy. So if I do a pyelogram, that is either an ultrasound or a scope or an X-ray of that particular part of the kidney. And typically we like seeing the whole setup, and that's called a KUB, or a kidney ureter bladder X-ray, also known as a KUB. So watch out, pyo and pus, they're really close. Here's, of course, urinalysis, lysis, breakdown, urine. What do we do? Ana means parts, urine. And this is the chemical part of it. And this is what we do at bedside, really quick. This is not super accurate, but if I just want to see something really quick, we use dipsticks. Hydronephrosis, abnormal enlargement of your kidney due to backup of water pressure. So if you got a stone, that's the first thing that happens. Because remember, this thing is really tiny, and you have a stone. And then another fearful sequelae that we have of stones is this thing. Because if that pressure backs all up here, what's going to happen? Do you think the kidney can do its job? No. And then the dirty blood gets to stay in the blood, and then your patient could have azotemia. Now, you could survive on one kidney, but it is not advisable. There's a reason why whoever made us with two of them. And the second you lose one, that's already adding considerable health to you guys. I mean, considerable health concerns for your future. Hydronephrosis, also known as, also you could get hydroureter as well. All right. This. Oh, continence is another way of saying your ability to control your urine and your feces. So incontinence, that means you can't either control your urine, feces, or both. Okay, and it could be neurologic, it could be a nephrologic, it could be a GI problem. There's a broad spectrum of issues on why you can't hold your urine or hold your feces well. Cystitis, that's easy. Polycystic kidney disease. Poly means many. Cysts. Now, this is all these little pus-like structures. And again, it's going to gum up the process, and it's going to cause issues. Let's look at what looks good. Acute renal failure versus chronic renal failure. ARF versus CRF. Chronic is renal failure that happens over a long period of time, like years to a decade. Now, the thing about, I totally forgot. Okay, gang, I have to, my wife is signaling me. I have an appointment at 7 p.m. With my physician. Sorry, I had to cut this close. I'm going to add an addendum video on top of this.